So Larry's said most of our speech. We run a health centre here in Brighton. Our centre is the only health centre in the UK that truly integrates NHS general practice with complementary therapies and healing arts, as far as we know. We believe that integration is an inevitable part of putting a patient's individual needs first. That if we are to truly deliver effective healthcare, we have got to integrate different approaches. I'm Chris, I'm an acupuncturist, and I've been in practice since 2003. And during that time I've run a complementary health centre, and I've built up experience working with hundreds of different therapists and different approaches to healthcare. This is Laura. Laura has been a medical doctor since 1996. And she's now the principal GP at our centre, the Brighton Health and Wellbeing Centre, that we run with our managing partner Gary, and we've been doing that for the last couple of years or so. Today we would like to talk to you about why our centre is important, about some of the challenges that we've had, and why losing control is an inevitable part of our collaboration.
Thanks. One of the first conversations that I had with Chris was about the use of acupuncture in fertility treatment. It was an important topic in general practice, and I was interested. So Chris told me about a couple that he's been treating very successfully. And I asked how long it had taken for her to conceive. And he said, "Oh no, she hasn't conceived." So I thought he must be clearly missing the point. But he explained to me that her cycle had regulated, that the couple were accepting of their situation, and they were looking positively at the future, whatever that might bring. And this made me think about all the couples that I have seen go through cycle after cycle of painful, heartbreaking IVF, often producing a baby at the end, but also sometimes at the expense of mental health, financial security, and relationships. And I started to wonder if it wasn't me that was missing the point. And then I wondered if in medicine as a whole, a lot of the time, were we really missing the point? Were we asking the right questions and looking for the right outcomes? And if we were, or if we weren't, was this really to do with the type of evidence that we have bound ourselves to use? And so I started to look more critically at the holy grail of evidence-based medicine. I didn't tell any of my colleagues this, obviously, or my friends at the time, because the very idea of questioning evidence-based medicine made me feel as though I might be struck down by a bolt from the blue, so heretical a concept it was. And as I looked through trial after trial, I thought about how all the endpoints are measurable, quantifiable, smart, and how many millimetres of mercury might a blood pressure be reduced by? How many days survival might a cancer patient expect to have? But in these trials, very little about quality of life, about overall mortality, about happiness or fulfillment. And in this reams of data, nothing about the patient's individual story of illness or experience. And I thought back about my training and education and about how I'd been drilled to value objective trial data over the individual subjective story. And so Chris, Gary and I resolved that we would try and create a primary healthcare centre which had the patient's narrative at its core.
We knew that this would be an organic and evolving process and that we'd have to take small steps. So in 2012, just before we set up the centre, I encouraged Laura to start sending me her most unwell patients, and she did. We wanted to pilot the concept of working together in an integrated way. Our first shared patient was a lady in her 50s called Julie. When I first met Julie, she was angry, a little obstinate, and she was dying. She was a real fighter though, but she was in complete denial about the seriousness of her medical condition. Laura had prognosed a short life expectancy. Julie had already been using a holistic approach to her health care for many years, so she started some acupuncture sessions with me alongside her radiotherapy and her medication. When she became too ill to come along to the centre, we visited her at home until she died of cancer in 2013. A few months before Julie died, she started to come to terms with the inevitability of the situation, of her mortality. Laura and I would spend time with her, holding her hand and holding a space for her to start accepting. She stopped being a fighter, she stopped being someone that was losing control, and she became more mindful and more peaceful. Julie died well, with dignity and with the end-of-life care that she chose to have. She was unusually lucky to be able to create the support network around her. She had the resources, a fantastic family, and the relationships to make it work. Her dying wish was that more people would be able to access that kind of care. And from that seed, we set up the Robin Hood Health Foundation, which is a charitable project within the Brighton Health and Wellbeing Centre that provides the funds to pay for complementary care for some of our patients, and it's especially those with long-term health conditions. So the centre came about out of the recognition that conventional NHS healthcare was losing control. All the boxes that need ticking, the backsides that need covering, the antiquated systems that were inefficient, they all work together to limit the actual purpose of being a healthcare provider, our well-being. So we wanted to find a way to get those necessary boxes ticked, but at the same time provide really good healthcare, giving patients choice in how they manage their health, empowering people to take responsibility, and recognising that the person is what should come first, not the illness that they happen to be hosting at that time. In fact, we recognised that we needed to take an approach more typical of a complementary health centre. So Laura and Gary invested in renovating our building, making it more open and welcoming. And we created a wellbeing art gallery in our reception area. We've run artist open houses, focusing on mental health. We have a team of 15 complementary therapists working in the building, and we run a healing arts centre, which is art therapy, narrative workshops. We do a singing group, we've got a dance and film programme running. We also run a healing clinic, an MS support group, a bereavement group, and lots more. People can always access these things independently, but many are referred to them by the doctors and nurses. We've made mistakes, and we certainly don't get things right all the time. The NHS cogs turn very slowly, and time and money are a constant hindrance. So we've tried to operate as proactively as we can. All our doctors and nurses and staff are paid for by the NHS in the usual way, but all our non-NHS services operate sustainably with financial independence, and they in turn provide an income into the charity, which then goes on to fund those in need. Integrating all our services is essentially done through being in close proximity to one another. In our weekly clinical meetings, doctors, nurses, acupuncturists, osteopaths, massage therapists, nutritionists, a mindfulness teacher, we may all be sitting around discussing together the best possible approach for a patient's care. Now, to a Brighton audience, that may not sound like much. It is actually unprecedented, but it shouldn't be.
Recently, I was interested to see this article by Professor Tricia Greenhow, Professor Tricia Greenhalgh is one of the UK's most revered academic GPs, an early proponent of evidence-based medicine. She's written lots of books and published lots of papers on it. And in this paper, she looks at how evidence-based medicine biases against patients. And one of the ways that she suggests that we can redress that balance is to put the patient's individual story higher up in the hierarchy of evidence. Mass trial data gives us a statistical or a probabilistic truth. And if you fall in the middle of that normal distribution curve, it will serve you well. But for the outliers, for the people on the outside there who might not respond to standard treatments, clinicians need the freedom and the flexibility to try different therapies and use different interventions, which may help that individual's needs better. For a doctor faces a single and singular individual in a consultation, and they have no way of knowing where on the statistical curve that patient lies. As Albert Einstein famously said, not everything that can be counted has value, and not everything of value can be counted. I look after an elderly lady who I met a couple of years ago at our reception desk. She was delivering a torrent of abuse to our reception staff. I tried to intervene, and she rounded on me in the same way. Doctors were awful, nurses were awful, the reception was awful. Her neighbours were awful, her family was awful, everyone in the waiting room was awful. She was in terrible pain and had the classic swollen joint deformities and muscle wasting of rheumatoid arthritis. She'd been in and out of hospitals, seen countless consultants and inpatient stays, and been given many courses of really expensive immunosuppressant treatments. Until the rheumatologist had despaired, there was nothing else they could do for her. And so, after a few months, we developed an uneasy relationship, and we looked at some other interventions that she thought might help her. Through the Robin Hood Health Foundation, she had a course of acupuncture with Chris, she joined our narrative workshops and our singing groups, and now she comes into the practice for a chat. She still has rheumatoid arthritis, and she always will, but critically, she has learned how to attend to her well-being despite her disease. People often ask me, how does acupuncture work? To which I can confidently reply, I have no idea. But it does. Not all the time and not for everyone, but it does. And so then people might say, well, how can you support something if you don't understand how it works? To which I can also confidently say, well, we don't really understand how the human body works. And in my readings, around all of this, I recently came across this little-known trial, which was reported in the Archives of Neurology and Psychiatry. A Hindu physician was authorised by prison authorities to conduct an astonishing experiment on a prisoner who was condemned to death by hanging. The physician persuaded the prisoner to allow himself to be exsanguinated or bled to death, assuring him that although the death would be gradual, it would be painless. I think this was clearly before the advent of ethical committees. But the prisoner, on agreeing, he was tied down to a bed and blindfolded. Unbeknownst to him, vessels of water were hung from each of the 4 bedposts, and the skin over his arteries was scratched without drawing any blood. The water was then allowed to fall initially quickly and then slowing into the vessels, into the containers of water on the floor. As the water slowed, the prisoner's condition weakened despite him being a completely healthy man. And as all the water emptied and there was a complete silence, he appeared to have fainted. On closer examination, he was found to be dead, despite not having lost a single drop of blood. Medically unexplainable phenomena like this happen frequently, but we dismiss them as freaky events, which have no bearing on the reality of science.
Freaky events happen all the time in my acupuncture practice. For a therapist, a person's freaky individuality is at the heart of what we do. A patient's personal experience is paramount. Their story is what I want to hear, and it's what they want to tell. It doesn't even have to make any sense to be of value. But the NHS typically devalues these stories with an ethos of restriction. The patient is sidelined in this kind of environment, and regulation just limits what the GP can do to deliver good quality care. Being a therapist at Brighton Health and Wellbeing Centre opens up a wider demographic of patients, but it's been a steep learning curve working with GPs. Time is a constant pressure on NHS staff, with so many people trying to access a service that is free at source. But mainly, we come from different health cultures. We're talking a different language. My therapist team are also up against the powerful mechanisms of conventional medicine. We're constantly trying to educate the NHS clinicians about different ways of looking at things. The answer to many people's health issues is not in a syringe full of their blood or on an image of their bones. Loneliness, isolation, lack of purpose, lack of self-worth, just not knowing how to live a healthy life, both from a physical and emotional point of view, can all be at the heart of someone's disease. We are making progress, and we expect it to take time, and we're just one centre in one town. My team are privileged to be working with GPs like Laura, who actually want to hear what we have to say. That is a loss of control for her, but it's driven by a desire to put the patient first.
Last week, the practice was visited by the medicines management team, and not in a good way. The lead of the medicines management team is a lovely woman, a highly intelligent pharmacist whom I respect hugely. But her unfortunate job is to impose the protocol and regulation of prescribing on local GPs, and she was apoplectic. Her main mission was to stop me prescribing a more unusual and expensive type of thyroid supplement for one of my patients, Catherine. I explained the story to the lead of the medicines management team. Catherine had been diagnosed in 1999 with hypothyroidism. She'd been given the normal standard treatment, levothyroxine, which is an excellent medication. It's usually highly effective and it works brilliantly for most people. But Catherine turned out to be an outlier. It was impossible to control her bloods. Her levels were all over the place. She gained weight, she lost hair, she wasn't absorbing it. She eventually lost her job and couldn't work, and her relationship started to deteriorate. She saw countless consultants and was prescribed lots of different medication, until in 2008 she bought herself some Armour from the internet. And it changed her life. Her blood levels stabilised, her body came back to normal, her mood stabilised, she went back to work, and her relationship thrived. And so I took over the prescribing of her Armour thyroid in order to ensure that it was sourced and monitored properly. But this story was not of interest to the lead of the medicines management team, and all she kept saying to me was, N=1, Laura, N=1. In evidence-based medicine, N is the number of people in a trial. So the more the value of N, or the more people in the trial, the more power that trial has. And what she was saying to me is that this is a trial of one, a patient's individual experience and story, and it has no value. Now this is something that we completely disagree with, and it is something that we intend to fight. We must be able to incorporate the patient's individual story and experience, or N=1, into our clinical decision making and our healthcare policy. We must be able to make decisions not only based on the statistical norm, but also on the premise that many people fall outside that norm and that we do not know everything. Effective patient management relies not only on the good understanding of statistics and data, but also in an appreciation of the art of healing, where a clinician can allow themselves to be guided by their experience and that of their patients. By discussion with other professionals, by common sense, and with humility. And so I have one question for you, and that is this: are you ready for doctors to relinquish their control? Are you ready for doctors to say, I'm sorry, I don't know, maybe I was wrong? And doctors, are we ready to share the platform with therapists, writers, philosophers, ethicists, to help us make humane, well-balanced and sensible decisions? I think we are. Any puzzle?
Thank you.